I'm going to talk about PCL tears today. Here's my disclosures. None of them really related to this talk. And just to reiterate, when we look at trying to step forward and do biomechanics projects, we try to look at doing a base of getting something ready for clinical translational research. So we consider all of our projects be pyramid-based. We try not to just jump around and jump at different projects. We try to be very focused and try to have a bench-to-bedside approach. When we've been able to do that for posterolateral knee injuries, for meniscal root tears, MCL tears, and PCL tears. I'm going to go through PCLs today. So this pyramid-based research approach is mainly to start out with the basics. For biomechanics studies, it's looking at anatomy, biomechanics, and better ways to objectively diagnose pathology. Then with that information, we can look at better anatomic-based reconstructions and ultimately validate what we've done with clinical outcome studies. So our team's treatment methodology, and a lot of this is done concurrently with Lars Engebretsen and his team at the University of Oslo. For the PCL, it's to quantify the anatomy, and we found out some very interesting information when we went back and looked at it in detail. Then to go back and revisit and reconfirm the biomechanics, and we had some award-winning research when we did that. We looked at better ways to objectively diagnose PCL tears. Then we looked at a more anatomic reconstruction, and we've been able to validate these reconstructions clinically. So the problem with the PCL, it's different than the ACL. The results are not as good. Overall, the results are inferior, and to the point where some people make recommendations to patients that have very severe PCL tears that they should just live with it because they can't make it any better. And probably 10 or 15 years ago, in most places, that was accurate. So our team tried to look at better ways to refine the surgical and rehabilitation techniques to try to improve this. So the first thing we looked at was the anatomy. This is something I did with Colin Anderson, who's a resident down at CU right now, and tried to define it better. We knew that there was an anterolateral bundle and a posteromedial bundle, but we didn't have good descriptions of exactly where they attached and what their overall function was. So if we look at this, the anterolateral bundle and the posteromedial bundle are attached in different locations. You can see them here. Posteromedial bundle is kind of more of a whip in the back. And as we flex the knee, they become tense in different locations. You can see this concurrently with the ligament of Risberg. And the landmarks that we also correlated with this are the shiny white fibers of the meniscus, and then arthroscopically looking at where they attach. You can see they're more on the roof of the notch and the wall of the notch rather than posteriorly. So they're not as far posterior as been described in the literature in the past. They're really pretty far distal and up against the articular cartilage. So what we wanted to do is to go and look at these arthroscopically and try to get better descriptions of where they attach. So we looked at bone box femurs, which is something we try to do with most of our anatomy studies, is to go and look at bony landmarks that we may miss. And this has really been kind of a key thing that we found through the years, is to look at the bones, and you can find some landmarks there in bony prominences that you may not recognize when you're doing the dissections. Then we did the dissections, and we tried to look at them in terms of standard anatomic axes, anterior and posterior and proximal and distal. And distal is kind of important for the PCL because a lot of the literature describes as trying to be as far distal as possible. So the PCL femoral landmarks, what we found out is that there's some pretty accurate descriptions of exactly where these structures attach. The trochlear point right along the roof of the notch in line with the trochlear groove, the medial arch point where it goes from a roof to a wall, and then the posterior point where at 90 degrees the articular cartilage is right up against the medial tibial plateau. And if you look at those locations between the trochlear point and the medial arch point, that's exactly where the anterolateral bundle attaches, so that's more of the roof. And then if you look at the medial arch point and the posterior point, you'll have the posteromedial bundle because that's the wall, and that's where these structures attach. And if you look at them in more detail, where you take them off and analyze them, you can see that the anterolateral bundle is right up against the articular cartilage here. And the posteromedial bundle is a little bit more oval shaped and has the meniscofemoral ligaments up against it. but the important thing to recognize is that these are on the wall, this is on the roof. So if we look at the distances between them, there's quite a big distance. There's 12.1 millimeters on average between the center of the anterolateral bundle and the center of the posteromedial bundle. And you can find these landmarks and distances, and they help a lot to help position things better in surgery. Now for the tibia, it's a little bit harder because they kind of blend together. You can see that this posteromedial bundle actually wraps around the anterolateral bundle, and the main structure component of it is on the posteromedial aspect, and that's where it gets its name from. But it actually curves all the way over and follows this bony ridge right here that I'll describe a little bit later. So this anterolateral bundle is on top of the ridge, and the posteromedial bundle is below the ridge. And if you look at the arthroscopic landmarks, the champagne glass drop-off that Mark Miller's described is something that is where the posteromedial bundle ends, and then the bundle ridge is right between the two bundles. And we can see that arthroscopically. It took a long time for our illustrator to get this right, but I thought it was really important to be able to take this picture and show what's going on arthroscopically. So you can look at the medial meniscus and the shiny white fibers down here. You have that point. And then you see this bundle ridge here, which is the landmark between the anterolateral and posteromedial bundles. And you can see that arthroscopically also, as well as this champagne glass drop-off and ultimately the popliteus tendon. And you can usually see the articular cartilage laterally, not so much medially. And then the oblique popliteal ligament is going to have the attachment to the tibia right there. And we can see these pretty reproducibly arthroscopically. And I think if you understand these landmarks, it's something that you can get in there very quickly and efficiently and not have to take 6 hours to do a PCL reconstruction on. So when we look back at the information, it's really hard to say that you can only have one tunnel for reproducing this big landmark here. So we feel that you need to have two separate tunnels. One for the anterolateral bundle, which is the strongest and widest portion of the PCL, but also for the posteromedial bundle. And with a large distance between them, it's difficult to reproduce them with one single bundle. And I'll show you later with some data that we have on that. And then this posteromedial bundle, the edge of it, if you drew a 7 millimeter tunnel, is going to be 5.8 millimeters back. So just the length of a reamer can be accurate for finding that position. Now the tibial implications are a little different. The center of the posteromedial bundle and the anterolateral bundle are a lot more compact, and they're separated by the bundle ridge. So they're just barely on top of this location. And if you look at the distance, it's only 8 millimeters between them. So we recommend one tunnel because of their compact tibial attachment, and it should just be right above the bundle ridge. So the implications are for the anterolateral bundle and the femur, it should be distal, which is right against the articular cartilage. The posteromedial bundle should be about 6 millimeters back from the anterior cartilage margin. And the PCL tibial tunnel, you should look at one tunnel because you really can't put in two separate tunnels. They'd overlap and it'd be difficult to do that. Now the meniscofemoral ligaments have also been described. We had quite a description also in our paper, but JBJS had us take it out. But basically, they're there most of the time. They attach to the posterior aspect of the lateral meniscus, and they're probably important to provide stability to the meniscus and some role of external rotation. And if you could think back earlier when I showed the video, you could see as the knee flexed, the ligament of wrist spur became very loose, so it really is more of a dynamic structure. So if we start looking at what we wanted to analyze here, we know that the PCL function we looked at historically, it's the main stabilizer of posterior translation. That's been known for over 30 years. 95% of the posterior stability to the knee at 90 degrees of flexion. And it was felt that the anterolateral bundle contribute mainly with the knee at flex to 90, and the posteromedial bundle was felt to be important in extension and also for external rotation. And that's been something that's been rote information for almost 20 years. But there really wasn't a lot looking at what happens with the PCL when you flex it in deep amounts. And we know that it's important when you get to 90. We wanted to analyze that a little further. So we went and did some studies here. It was a two-part study, like a lot of our studies in the robot. And we wanted to define the individual and collective functions of the two bundles of the PCL. and wanted to use that to be able to go on and look at anatomic single versus double bundle reconstructions and put a nail in the coffin of that analysis. So we looked at 10 matched paired cadaver knees. So you can imagine how long that took because these studies take so long. And we used the robot, and we looked at sectioning each one individually and then completely sectioning the PCL to see what happens. We found some interesting information. It had been, the UCLA group had done a great study where they sectioned just the posteromedial bundle, and they found out it didn't do very much. So through that information, they said that we really didn't need to have double bundle PCLs. But you can also look, when we just sectioned the anterolateral bundle, it didn't cause much translation, so you can have reverse logic and say you didn't need to reconstruct that. And these are really codependent. This is something that's been just recently described in the literature. The two bundles are dependent on each other. And you can see when you have both of them sectioned, there's a lot of increased posterior tibial translation. But when one of the bundles is sectioned, there's still quite a bit of stability to the knee. And most of us would hardly pick this up when there's only 2 millimeters of posterior translation with one of the bundles gone. So if you've got 6 or 8 millimeters of posterior tibial translation, both bundles really have to be injured. It's not just a single bundle PCL tear. And we also found out some new information at higher degrees of knee flexion that there was a significant amount of internal rotation. I'll come back to that later. So what we found from this study, and when we went to look at the single and double bundle reconstruction, they both resist posterior tibial displacement through all degrees of knee flexion, from 0 to 120 that we tested. So there really is a codominant relationship. And the PCL bundles are definitely synergistic in load share. So the next thing we did was to go to anatomic reconstruction. So we looked at putting reconstruction grafts in the center of the attachment sites and looking at both anterior and posterior stability as well as the rotatory stability of the single and double bundle reconstructions. So we looked at single bundles, just reproducing the anterolateral bundle, and then looking at also a double bundle reconstruction. And we use matched pairs for that. So if you look at the difference here, when you have a completely sectioned PCL versus the green, which is a single bundle, and a yellow, which is a double bundle, you can see if you really want to have somebody do well with a PCL reconstruction, you have to do a double bundle reconstruction. There's just no way, and this is exactly where the literature sits for single bundle reconstructions. Almost all the data in the literature shows that we end up with about 5 millimeters of posterior tibial translation on stress x-rays at 2 years. So that fits with this data. And if you look at the double bundle reconstruction data, which there isn't a lot, but this fits with our data, we're getting people back to within 1 to 2 millimeters of posterior tibial translation. And you can also see at the higher flexion angles, it's even more important, where athletes that are skiers or do a lot of knee flexion in their particular sport would need a PCL that functions well. We also found that we can restore internal rotation a lot better with a double bundle reconstruction, so that posterior medial bundle was important to be able to restore the internal rotation. So if we look at that, the double bundle reconstruction, as we have outlined here, more closely approximated native kinematics, it definitely provides better restraint to posterior tibial translation, and there's less internal rotation laxity. Some of the other data that we did when we were in Minnesota with Lars was to look at the effect of posterolateral corner injuries on PCL reconstructions. This is old information, but I think it's important to look at. And we found out that when you have a posterolateral corner injury, it significantly overloads a PCL graft, both with varus, which is a key part for ACLs, but also with coupled posterior drawer and external rotation. And part of the reason we did this is, one, we were seeing patients that had failed PCLs that had posterolaterals, and two, it was driving us nuts that people would go on the podium and said they had a patient with a PCL and a posterolateral, they did the PCL reconstruction, and then checked the posterolateral, and it was nice and tight, and they didn't need to do anything. And obviously, all they did was overload the PCL graft, and that's why we're having so many failures. So you really have to decide on your exam under anesthesia what you're going to do, and not put a graft in there that'll overconstrain the knee and not give you accurate information. Now, from that, we wanted to look at tensioning studies, and this is something that Nick Kennedy won the Excellence in Research Award to AOSSM meetings ago. And we we found that there was a lot in the literature in terms of where to fix different grafts. We wanted to go and test that so we could try to get the best graft positioning. So for single bundle reconstructions, people were tensioning it anywhere from 75 to just past 90. And we found out when we assessed it that they were all the same basically. 75 up to 105. There was a slight improvement of decreased posterior tibial translation, but it wasn't significant at 105. So if you're going to tension it, you probably want to fix it at 90 to 105 rather than 75 to 90. But there was still some persistent laxity compared to the intact state. There was increased posterior laxity. There's still the external rotation, internal rotation differences at higher flexion angles. Then we looked at double bundle PCL tensioning. And we found that we're basically getting back to normal. The posteromedial bundle fixation angle, if you didn't fix it in full extension, it was over tension, it was probably going to stretch out. And it was important because some people in the literature are fixing it at 90 and others at 45 and weren't getting their outcomes as good. And I think this helps to explain why it was being overconstrained. And then the anterolateral bundle was better fixed at 90 or 105. Those are basically the same. So what we're finding out is that if you fix this in extension and you fix this one at 90, it's probably the best positioning to do it. And it's been validated with clinical outcome studies. So that was our analysis on the base of the pyramid. Then if you look at the history of PCL tears, most of these patients describe instability. They don't have a lot of pain. They'll have difficulty when they're athletes at quick deceleration. So basketball players can't decelerate, soccer players can't decelerate. And also people when they're descending stairs and hills. And it makes sense because they're going to plant their tibia, then their femur is going to roll forward on the tibia. And then some of these people will have medial and patellofemoral pain. Those are usually the chronics. Those are the PCL tears and NFL football players that come to see us 10 years later, and they've got a significant amount of patellofemoral arthritis because of all the work they had to do to keep their knee in position. So when we're looking for posterior tibial translation, one of the things we'll look for is the sag sign to see where it sits. And then concurrent with that, we'll do the quadriceps active test. And that's probably the most reliable. So you can see the sag sign is a starting point and pulling on the quads. And firing with the quads will reduce the sublux tibia. If you do an exam and it's difficult to determine if there's a partial PCL tear with an ACL tear, just do this test. Because by definition, you shouldn't have it pull forward with a quadriceps active test. Then assessing of posterior tibial translation, we'll do the posterior drawer test. It's important that it's in neutral and roughly at 90. You can see from our data we showed earlier, even up to 105 may show an increase in posterior tibial translation. And then we just apply a straight posterior force. PCL stress x-rays are much more accurate. We've had a lot of patients sent to us for analysis that were told they had a grade 1 PCL tear or a grade 2 PCL tear and they kept having symptoms. And then we'll get the stress x-rays and it'll show a 10 millimeter side-to-side difference, which is a complete PCL tear. So it's one of those things that in America we use this a lot to describe it, but in most other countries around the world they only talk about PCL stress x-rays. They don't talk about a grade 1 to grade 2 or grade 3 posterior drawer test. We also looked at the supine internal rotation test. So we followed a large number of patients. It was over 300, and we looked at the amount of internal rotation they had as part of our data collection here at the Institute. And we found out that PCL tears did have an increased amount of internal rotation at higher degrees of flexion compared to any other ligament injury we had. So that's another thing. The problem is obviously you're going to have a positive posterior drawer test and everything, but it'll help you to analyze when you do have a PCL tear to confirm it when you see this increase in internal rotation. Now what about radiographs? X-rays may show an avulsion fracture off the back of the tibia. I think this is probably showing more of an ACL tear, but you'll see it on the posterior aspect of the knee. MRI is very useful for acutes. It's not very useful for chronics because the PCL almost always heals. It'll heal in an elongated position, so you can't use that very accurately. But MRI for acutes is almost 100% accurate, and then we use stress x-rays also. So here's the radiographs. We can see here with a PCL avulsion fracture, and we can see that there's a little bit of posterior tibial subluxation here on the femur. So you can just look across the room and see that. Probably one of the most important things is to follow this up with an MRI and see what else is attached there. Because the meniscal roots can be attached there, there can be significant amounts of articular cartilage So it's important to look at that in addition to the PCL tear. And then stress x-rays, these really need to be done. If you treat PCL tears, you have to get PCL stress x-rays. And Mark Miller and John Sakia have done a lot of landmark work on this. We've also done some. And basically, if it's less than 8 millimeters, it's considered a partial tear. But if you look at our biomechanics data, that doesn't quite fit with a partial tear. It's probably more the patient isn't kneeling on it. Once we get to 8 millimeters, it's a complete tear. It's probably not going to heal unless you put them in some type of brace that'll push them anterior in an acute situation. And then we get 12 millimeters and above. This is pretty much the international standard that there's probably a combined ligament injury there. So when you see this side versus that side and you see that there's a 20 millimeter difference, there's probably something else there. Most of the time, it'll be a posterolateral corner injury associated with a PCL, but it can be a medial-sided injury. The important thing to recognize, and the postgraduate thing for fellows, is that if you do have a decrease in the posterior tibial slope, there'll be some increase in posterior tibial translation. So if you examine them and you do the stress x-rays and there's no varus and valgus gapping and you don't appreciate any rotation differences, look at the slope, because the slope may be so flat that you'll have a little bit of increased posterior tibial translation. So the posterior translation differences, we want that to be, for isolated injury, 8 millimeters or less. There really shouldn't be a lot of external rotation laxity and no significant varus or valgus instability. Now, MRI can be very useful. It can show you if it's a mid-substance versus a peel-off tear. You should also look for root tears. Some of the older literature showed that primary pairs of PCLs did okay, but in general, they're only about 60% successful. And when I went to college, that was a D. So we really, if you do have a PCL tear, you should be doing reconstructions. You shouldn't be doing repairs. Now, if they do have preoperative stiffness, we'll consider prehab frequently to try to improve their range of motion. The only time we wouldn't is if they've got a bucket where they obviously need to get in sooner and they're not going to get their motion back very effectively. But we want to try to get the edema under control, get their motion better. And we probably don't have a better place in the world to do that than here, because we can get patients in immediately and they do magic on these knees, and within 2 or 3 days sometimes they go from a knee with a very little flexion arc to almost full range of motion. Now, when we look at double bundle PCL reconstruction grafts, what we've used is an Achilles tendon allograft for the anterolateral bundle. It's pretty much what about, if you look at the systematic reviews, it's about 80 to 90% of people around the world use that. And then for the posteromedial bundle, you can either use a semitendinosus allograft or a tibialis anterior allograft. It probably doesn't matter as much. The PCL has a little bit better blood supply than the ACL, and it doesn't seem to have the problems with allografts that ACLs do. So if you're looking at the technique, we're going to look at where the attachment sites are, outline them. You can see the trochlear point, the medial arch point there. So we go in and outline them individually, and also outline the posteromedial bundle. And then we'll use a reamer, just a simple way, and make sure it's right up against the articular cartilage. For the tibia, we're going to put in a posteromedial portal. So we do that on direct visualization. You can see the shiny white fibers down here, and then you just debride down and find the attachment site of the PCL and the bundle ridge. We strongly recommend getting intraoperative x-rays. It's felt that when we do these courses at the Academy and instructional course lectures, 100% of the time we really want people to get them, because the tibial guide pin placement is probably the key point of getting this in a most accurate position. So it should be, the entry point is almost always 6 centimeters distal to the joint line. And then posteriorly, we want to be about 6 to 7 millimeters proximal to that champagne glass drop-off on the posterior aspect of the tibia. Then we verify this with AP and lateral fluoroscopic images. The fellows know this only takes a couple minutes to do this, and it's worth making sure that we get things in the correct position. We validated this. Adam Johansson, who's now a resident at Stanford, spent a summer here, and we did this study here at SPRI, and we found out that we can get reproducible guidelines to look at where they attach. And for the AP and the tibia, if you look at the true joint line, now in the literature in the past, it was just more of a guess, but it was said that you had to be 1 centimeter distal to the joint line, and all the guides were based off of that. But in actuality, if you look at the true joint line and you make sure it's flat when you get your fluoroscopy. It's only about a millimeter, 1 to 2 millimeters distal to it where the center of the PCL is. So that's a good landmark to look at. You just have to make sure when you're getting your fluoroscopic images that you have a true AP and you don't have overlap with the tibial plateau. On the lateral tibia, the PCL attachment site should be about 5.5 millimeters from the champagne glass drop-off, which will correlate to about 7 millimeters when you're crossing that posterior point that Mark Miller warns us about, breaking out the back and getting the artery. So it's important to make sure that we're far enough down and not so far up that you can take out the meniscal roots. And we've done some studies to show that you can do that, and some of our patients that we've seen here in a series of patients have had their roots taken out because this tunnel was not checked with x-rays and they took out the root attachment. So if we look at the surgical technique for the femur, we find where this anterolateral bundle is, once again being as far distal as possible, and then we place that reamer at the roof, and then we'll drill an eyelet pin through it that comes out on the anteromedial aspect of the knee, and then we'll just ream a closed socket over that. It's easy. You just have to ream that closed socket. And then concurrent with that, we'd also look at the posteromedial bundle. So we've got the anterolateral bundle. We're trying to have about a 1 to 2 millimeter bone bridge between the two of them. And you can see we just place this in and over-ream it and pass a passing stitch. For the tibia, I think it's important to make sure that there's no over-penetration. So we'll put the guide in. We'll check the x-ray. And then when we're reaming this, we should have a big curette in the back of the knee just to make sure there's no over-penetration. We try not to ream through the posterior aspect of the tibia because that's been shown to have some complications in the literature. So we try to exit the point back there by hand, and then we'll pass a smoother device up through there. I like to use a smoother device because it cleans off the aperture. It makes it very easy to pass the grafts down the tibia, and then you can later use it to pass the grafts down the tibia concurrently. So here's the posteromedial bundle graft being pulled in. It's just like an endoscopic ACL, but it's right in your face, so it's easy to get there. I use a bioabsorbable screw for the soft tissue graft, and that's just something we could do quickly and efficiently. Same thing for the anterolateral bundle. We'll pull that in place, making sure the bone plug is more posterior, so you want the bone interface up against the cartilage. It's important to have a graft protector when you're placing this one in, especially for the Achilles graft. And then we can fix it in place right at the roof of the notch. So passing them down the tibia, you see it already happened, but it's something that happens really quick. So you pull this, you put the grafts on the end of the gore smoother and just pull it down the tibia. You can see it coming out on this side. And then you individually tension them. And when I was a fellow, there was times that it took 2 hours at the Houston clinic to pass these grafts, and I was determined I was going to figure out a way to do it a lot easier. And this is a lot easier and quick and efficient. It's very rare that we have anything not pass within the first 5 or 6 seconds. So then just to show it again, where you can see it being pulled down the tibia, I think it's an important thing to demonstrate. So fixation, and then fixation in the top. So just based on our biomechanical data, we want to fix the anterolateral bundle at 90 degrees, and then the posteromedial bundle we're going to fix at 0. And I like to use a screw and washer. I used to use staples, and when we used the staple in the robot, we broke a $6,000 piece of equipment. So I switched over to screw and washer for the robot study. Then we started using them in patients. And we found out the patients had about 90% less pain, so we figured out that most of the pain from PCLs was because of insertion of the staple. So once we get the grafts in and we fix them, we want to ensure that we've completely eliminated the instability. So I'm going to show you a case example here. You can see the difference with the pseudo-Lockman. It's important not to reconstruct the ACL when you see that pseudo-Lockman test. You see the difference in rotation, side to side. So I like to use big arthroscopic portals because we have to pass the grafts through them later. It makes it a lot easier to jump side to side. You can see the ACL slack sign there. I had a series of 7 patients in Minnesota that had their ACL reconstructed when there was a PCL tear because it was felt it was a positive lockman, so don't do that. Then we'll go in and clean out any adhesions within the joint, check the menisci. It's important to always look for the root attachment right there. And also check the lateral meniscal root because they're so close to the PCL, sometimes they'd be concurrently torn. And this patient had a small radial tear of the posterior aspect. And then we're going to outline the anterolateral bundle. Remember, distal is good. If you make it more proximal, the biomechanics are bad for the anterolateral bundle. So distal means right up against the cartilage. And then I'm going to also outline the location of the posteromedial bundle. And then we'll use a guide. So it's just a simple reamer. And then through that reamer, we'll ream a beath pin. And then just leave it in place and change the power out and just ream over it and create a closed socket. So it's a pretty quick and efficient way to get these tunnels. And I like to have my PCL tunnels done within the first 5 minutes of the surgery because you get those done and then you just have to worry about the tibial tunnel. So we try to make sure it's 25 millimeters in depth. Don't want it much deeper than that. And then we'll place a passing stitch in. That makes it easier at the end of the case also to get these passing stitches done early. And then we can reference off that. It probably doesn't matter if you overlap a little bit at the aperture here because when you place in this other tunnel, it's aimed a little bit differently. So you're going to have some offset. You don't have to worry about that. And then once again, I like to take it out by hand, clean around the tunnels, and then place a passing stitch. So we get this done pretty quickly and efficiently, and we can verify that the tunnels are exactly where we want them. And because it's directly in front of us, it's a lot easier. The other thing is with this technique, you can see there's a little bit of overlap there. The other thing with this technique is we don't have the VMO shutdown that you have when you have to have a big incision from inside out. And it makes the patients recover a lot faster. So now I'm going to make my posteromedial portal. I'm going to go right just posterior to the posterior oblique ligament. And then clean out. You can see the shiny white fibers down here. And then clean down. This is an archaic guide. It's about 20 years old, but it still works well enough that you can get the guide pin in position. And I like to place it right on the bundle ridge. You can kind of see a hint of the bundle ridge right there. So I can get the guide pin in place. And then we can check fluoroscopically exactly where it is and if we want to change the position or not. Same thing with the AP. Remember, it's about 1 to 2 millimeters distal to the joint line. And then I like to put a large curette through the back to protect for overpenetration. And then ream directly over that. So once it's reamed, we'll pass the gore smoother out. We'll pull it a few times to clean off the aperture. You see me pulling on this side better than arthroscopically. But it really makes a difference in cleaning out that aperture. It's far enough distal you don't get it in the way of the roots. And then we'll start passing in the grafts. So first, posteromedial bundle. It's the one you should pass first because you can fix that and still fix the anterolateral bundle without interfering with it. So we like to mark it with methylene blue so we can see the depth. And placing in a guide pin. It's important to notch that little position where you put the guide pin in, otherwise sometimes the screw doesn't go in directly where you want it to. So we'll get that in place, then I'll pull hard on it to make sure I've purchased it well enough. Then we'll pass the second graft here. You can see we're passing the sutures in. And then pulling the bone plug in. Sometimes you have to use a little elevator like I had there just to push it down in place because it won't pull in directly, but it's something you want to make sure that you get it in good position. Now both of them are fixed. Then we'll put the sutures in the end of the gore smoother like I talked about earlier. It may not have been clear, but then you can use this to just pull them down the tibia. And that was one of my main goals in this procedure, is to make sure I didn't have all that time passing the grafts. So we could turn it from a 2-hour procedure to a 30-minute procedure just because of the fact we can do things quickly and efficiently. And then we're going to put in the screw and washers. Probably the big thing with this is make sure you tap the tibia because the cortical bone is very hard. And then we'll concurrently fix this at 90. And the second graft we'd fix in full extension, the posteromedial bundle graft. And then once we get both of those in, we're going to verify that it's completely eliminated the instability. Pseudo-Lockman's gone. Posterior drawer is gone. We can view arthroscopically. One of the big things to look at is make sure that that ACL slack line is gone. If the ACL is pulled back in position, your graft should be nice and tight. And then we can just go from here and close the incisions. So you really can't do all this work down here without ultimately proving it works. So clinical outcomes are kind of the top of the pyramid and what we want to do. And this is our clinical outcomes results. We looked at 39 patients, some revisions. A lot of them were combined. Average follow-up 2.5 years. And if you look at their outcomes, Cincinnati's start off pretty low, even though a lot of these are chronics. And then you can get them up higher. You're not making them the same as ACLs, but you can get them improved. I'll show you some other data. The issue is that the chronics improve some, but not a great deal, whereas you can see the acutes make a big difference. So that's why I try to push people when they have a lot of instability to do them acutely, because the outcome studies show that there's a significant difference there, even though the PCL stress x-rays are exactly the same. So there's other structures that are injured, their proprioception probably isn't normal. So if you look at acutes versus chronics, I'd take that to the bank. The problem is that when you get these chronics, even though you make them more stable and they're doing a lot better functionally, their outcome scores aren't quite as good. So we ideally want to get in before they have all these other injuries going on. So the double bundle reconstruction technique, I think one of the key points is no violation of the VMO, which is important to get that back and functioning for PCLs. The graft passage is significantly easier, and we're finding out that we validated what we've seen in the robot. The robot makes a huge difference with a double bundle versus a single bundle, and our PCL stress x-rays are a lot better than the single bundles in the literature. The other thing to analyze also is the postoperative bracing principles. We want to have early range of motion. Up until about 2 years ago, I used to get killed from the podium every time we have an instructional course lecture at the Academy by Mark Miller and others, Greg Finelli, that they felt that PCL should be kept in extension for 2 weeks. And then they concurrently were having 30% risk of arthrofibrosis, whereas we were starting early range of motion and our arthrofibrosis is less than 2%. So it's important to make sure, one, the grafts are in the right place so you can do this, but also you have to protect them from posterior tibial translation, and the brace can help do that. So at the time that we wrote this paper just a couple of years ago, there really was only one brace that worked effectively. The other ones were just straps, and there wasn't a lot of evidence validating their biomechanical effectiveness. So what we found out with the JAG brace, those of you who have seen it, it works, but it's cumbersome, and you can't use it very long because you can't use it to return back to sports. There really was not any functional brace out there for athletes, and we felt there was a potential for a dynamic brace that better replicates the anatomic force applied by the native PCL. So we worked with OSER to help develop this new brace. It's something that we worked on for 5 years, and we found out that the brace did very well in terms of restoring the overall stability to the knee, and it's similar to the native PCL. So concurrent with that, we use the brace to minimize posterior sag during rehabilitation. We work on early quad activation, and one of our main principles is to start prone knee flexion. So we don't like to have supine knee flexion because in that position, gravity is going to pull against the graft. So we want them to buy into the whole program, and especially for the first 6 weeks, primarily work on prone knee flexion to protect the PCL graft so you don't have the posterior translation problems. We also try to avoid the hyperextension for 12 weeks, and we're really working with our therapists to hold the tibia forward when they work on their range of motion to prevent posterior tibial translation. This is level 5 evidence, but almost everybody does PCL surgeries, tries to avoid isolated hamstrings because the hamstrings are going to pull on the PCL graft, and we keep them non-weight bearing for 6 weeks right now. We do a lot of exercises that we've outlined. The other thing that we looked at is PCL complications, and Mark Miller has done a great job at analyzing these, but one of the things we found out, which really hadn't been reported before, was when a PCL tunnel is incorrectly placed, it can take out the root attachment. So we've had a series of patients that were iatrogenically had injured roots. You can see here on the CT and also on this one that the root can be taken out because of the tunnel placement. And that's why you have to get intraoperative x-rays. If you're off by only 2 or 3 millimeters, you can take out the root in some patients. Mark's had a lot more dramatic complications in his studies. Popliteal artery injury is something that can happen. You can see here also inlay technique, same thing can happen. So it's also important to visualize the guide pin. The other thing for the fellows is you want to use an acorn reamer. You don't want to use a full bore reamer for the PCL, because with the acorn reamer, if you're starting to hit this back wall, which is where one of the places Mark showed there was popliteal artery injuries, you can feel a chatter with an acorn. You can't feel it with a smooth bore. You can drop your hand and walk along the back wall so you don't break out the back. And that's just kind of a postgraduate way to deal with this, but it's important so you don't have a PCL injury. Other complications, they described osteonecrosis, fractures, obviously arthrofibrosis. Residual posterior laxity is the most common. Some of these patients will have anterior knee pain. And you can also develop compartment syndrome if it takes you 6 hours to do a PCL. So what are the further issues we need to do with PCL reconstructions? We want to get earlier healing. I think that's important. Hopefully with Johnny Heward here, we can work on better ways to have biologics, to get VEGF in there and get a better vascular supply. The PCL does have a better intrinsic ability to heal, but it's not there yet. We want faster rehab. We've done some studies in the lab now that show that with partial weight bearing that it's probably safe. So we have an ongoing level 1 study. We're looking at early partial weight bearing with PCL reconstructions to see if we can start some early weight bearing safely. The other thing is double bundle PCL reconstruction works. It's more effective. And I think the old argument that PCL surgery doesn't work and that's why you shouldn't have it has pretty much been invalidated by our work. So in conclusions, double bundle PCL reconstruction significantly improves patient overall outcomes. It's definitely improvement in subjective outcomes as well as objective knee stability, so they go hand in hand. I think it's important to single stage all surgeries. Make sure your team is there. Stage surgeries have a higher risk of lower outcome scores and a higher risk of having decreased subjective knee stability. The reason people do it usually is because they just don't have the team there to do it. So if you're going to look at staging surgeries, I'd encourage you to try to make sure you assemble a team so you can do them all at one stage. And I strongly recommend our approach or something similar to our double bundle PCL reconstructions. Thank you. Any questions? Yes.
Technical question. When you're during the surgery, when you're aiming for the anterolateral and posteromedial bundle in the femur, where do you aim the exit point, especially when you have like a concomitant MCL reconstruction?
So the question is where we aim the tunnels when we're making the closed sockets in the femur. And it's probably more of a 45-45 angle for the anterolateral bundle. So it's coming out just a little bit posterior to the adductor tubercle, so not at it. So if there's an MCL reconstruction going on, you should avoid it. And for the posteromedial bundle, it's just a matter of angling it a little bit lower. So it's making sure that you have a little bit of divergence with those two tunnels so they don't completely overlap. Honestly, I don't know exactly what my angles are because we've done so many. I figured out in my head, and I know Gilbert's going to tell me exactly what they are when he looks at the CT scans. But right now, I can't say exactly what the numbers are.
It's 45, 45.
It is 45, 45. That's just kind of what I guessed.
Thank you.
Any other questions? Justin?
PCL posterior lateral corner. What's the sequence that you fix those in?
So the tensioning sequence for injury is what's being asked. So we don't really know. Historically, it's been felt that the PCL is kind of the pivot point for the whole knee. So you fix the PCL first. And we know that based on some of our other studies with the posterior lateral corner, that you should fix the posterior lateral corner before an ACL. So if you have an ACL, PCL, posterior lateral corner, we'd fix the central pivot first, then the posterior lateral corner, then the ACL. Gilbert is going to do a study looking at that with 7 different graphs to look at the best fixation combination. It really hasn't been analyzed, but that's part of his PhD thesis for Norway. So he'll be doing that within the next few months.
To add to his question, what sequence would you drill your tunnels and pass your grafts for multi-leg ACL, PCL?
So the question is, when we drill the tunnels,
Yeah.
you guys know that I do the collaterals first because I want to find the structures before this fluid extravasation. So we'll always drill them, whether it's a medial or posterior lateral first, and place in the passing stitches. Then what I like to do is the femoral tunnels first, and usually it's a PCL, but sometimes I'll do the ACL if I feel I can do it quicker. It's just a matter of how much debridement I have to do. And then I'll do the PCL guide pin. And if there's some other things going on, like a root repair, I'll also put that guide pin in so I can make sure that they're not too close to each other. And then I'll do the ACL last, after the PCL graft is actually passed and in. But for passing grafts, I always do the PCL first, because you can't do an ACL after the PCL is already there. So you do the PCL first.
For your
Alex?
chronic tears, people that come in 10 years out, what's your kind of clinical decision process about whether you think putting them through a reconstruction is going to be beneficial versus any other options that you might be able to offer them?
So for the chronics, that's the question is, it's just like an ACL. You have to figure out what their problem is. Do they have pain or instability? If it's pain, maybe they've got some medial compartment OA.
Okay.
And then you can look at a biplanar osteotomy as an option. If it's instability, obviously you have to look at all the other associated factors. But instability would be a PCL reconstruction probably first. Pain, assess them to see if they have any joint space narrowing, look at their slope, see if they're in varus. And you might be able to help them because biplanar osteotomy, as you guys have seen when they come back, really helps a lot for PCLs. You increase the posterior slope and they're a lot more stable. That's what Steve Heiserman had. Went back to play in the NHL for a couple of years. He had a PCL tear that was not treated, got osteoarthritis of his medial compartment, had a biplanar osteotomy by Pete Fowler, and played for 2 more years after that. So it's something you can get somebody back to a higher level than probably you can with an ACL with an osteotomy, where it's really difficult to get them back to high-level sports. Any other questions? Gilbert? You always have questions. Nothing? Okay. All right, thank you very much.